chairpersons Dr. Bharat Kadadi, Dr. Caroline Like, to come onto the dais, please.
So the ISSH Indian Normative Data Project session will be in Orchid Hall. So we'll now, again oration is there, no? Yeah. So now we'll have parallel session in all the three halls, and again we'll assemble in Galaxy Hall at 11:45 for Professor B.B. Joshi oration. Thank you.
Welcome all to this session, going beyond the Scalpel, Philosophical Reflections in Hand Surgery. Can I request Dr. Rajasabhapati to speak on unifying forces, strengthening the hand surgery community for greater societal impact?
Good morning to all of you. I think we had a fantastic lecture by Professor Tori. And this is the topic given by Bharat. It made me thinking. He says, if you say greater societal impact, I think it's a very heavy topic. You can talk for 8 minutes. We can talk for 80 minutes. And it can be perceived very differently by different people in different phases of their lives. For example, Dr. Christian Bernard, who made the first heart transplant, towards the end of his career, he said this. He said, I have saved lives of 150 people by heart transplants. If I had focused on preventive medicine earlier, I might have saved 150 million. So that's the societal impact. I think you tell it at a different part of your life. So, but then all of us are committed to become hand surgeons. We are hand surgeons, and if we have to make a big impact, I think we can only make impact in, I thought in 5 ways we can make an impact. One is by our own profession and the institution we build, teaching and training, research, community needs, and organizations and influencing. So the societal impact, I think I standardly believe that charity begins at home. See, you can't make an impact in the world if you don't impact in your city. I think first of all, I think everybody in your institution has to respect you. And every hand surgeon must work to a stage where, if you are working in a hospital, I think everyone in your hospital have to feel that the hand surgery department is a great department. I think that's exactly what happened when Professor RV set up it in Stanley. So you can't sustain to make a big impact in the society without impacting the place of your work. So that's the first point. And how do you get there? I think you need to work beyond the purpose, beyond yourself, and putting the interest of the patient first. I think you need to make the institution grow, and you must be an institution builder. I think that's very important. But then when I say you have to be an institution builder, not necessarily you have to be the director or the chairman of the hospital or the chairman or the head of the department. I think what really makes people build is that you need to take ownership of the problem, that is taking responsibility. Then over a period of time, you will make an impact. So you need to join hands to make an impact. I think that's very important. For example, if you take a brachial plexus, I think what was talked by Professor Tori, see, their institution is one. He's an orthopedic surgeon. He does he does FFMT. So their institution is just like ours. We can take from shoulder arthrodesis to FFMT. So if your orthopedic science and plastic science work together in a case, that means what happens is that we should be able to deliver what is ideal for the patient and not what you can provide to the patient. And either you must be capable of creating a great institution or you must be part of one. And you should, if you are part of one, you should be to align to the institution's core values. I think that again is very important. So next is impacting to the community. So you need to look out for the need. I think if you just look at the community, there is tremendous need everywhere. And look out for the gaps. And don't complain. I said, I used to often say in our hospital, suppose before complaining about anything, please ask yourself the question, can I do something about this? I think most of the times you will be able to do something about it. And before talking to me, please just ask that question and then answer that question. And then if you really find, many of the times you will be able to do it yourself. For example, see, this is a problem in the community. See, this is a girl, you see her, this is a right hand. See what's the function she has got in the right hand. And that's the left hand. So and she's been living here for about so many years she has been having. And then that's after reconstruction. So that is, she is able to do, but this has been done totally free under a major project that we have. So if you get into the society, you will find that you will be able to create an impact into the society by very many different ways. And there are a lot of people like this. I think she has been a migrant worker living in Chennai, has been like this for a few years. I think they all fall outside of the radar of the healthcare systems. That's the face. And that's the left hand and there's the right hand. So if you have this, if you have to really reconstruct this, and then it's extremely difficult, and we've gone halfway through, and then we're getting it there. So we make a great societal impact when you take care of patients who fall outside the radar of the healthcare systems. So when you do that, you expand I think this is exactly what you have done in the diabetic foot case, and I always believe that if you work really hard, the universe will conspire to help you. I think that is very important. So we started this project in 2012, and the total amount of free surgeries we've done is $1.35 million. There is 11.3 crores, and it's just going to cross 1,500 surgeries. Every month now we do free surgeries in burns alone for about 10 lakhs. And then it doesn't come easy. I would have made over 500 presentations for work fair. I will do it anytime the same, even if I have to do it for one fellow, I will do it, and I make a presentation especially for that person. The next is teaching, teaching and training. What you need to do is that you need to help others to grow. I think that is exactly what Dr. Manjunath also said yesterday. You need to provide space for growth. And you need to have multiple verticals, and you have to see that everybody has to do much better than yourself. Then you become taller. Our greatest strength has been our visitors. Over 3,280 surgeons have visited our unit from 83 countries, and they are our best quality control inspectors. Then research, I think most of the time, our Indians, we all say that I'm very busy with clinical work, no time for research. To make an impact, you need to think that doing research is part of patient care, it's part of clinical work. I think then you will also do this. So you have to think that this is also part of clinical work. Numbers with quality combined with intellectual honesty. I think all of us can do this. I think we have numbers, we can do quality work, and we are intellectually honest with numbers. I think it becomes an unbeatable combination. I think all of us can easily do that. The last part will be organization, like an ISSH, IFSSH, or APSI, IOA. You need to become a useful member of the society. I think when I say useful member, I think usefulness comes from contributing and not by mere questioning or creating issues. I think that's a very, very important point that you have to make. And what we really have to make is that you need to do something to make another member better. I think people around you better. I think that's very important. And there is strength in numbers. I think what we have to do is good people to have to align together. I think that's very important. That's very important. And be present. See, we need to attend national and international meetings. Only if you go, you will know what you will get. I think you just simply can't ask, what will I get if I go? But you will go, you will know, I think only because if only you attend Dr. Hattori's meeting, you will know what Hattori has done. So we can't ask, what he would speak without coming. So even here, think how to contribute, then just be there. I think that again is very important. And the last part of it is ability to position yourself where you can influence public policy. But a lot of us say, no, politics is bad and I don't want to discuss, I don't want to attend administrative meetings. And a long time back, I heard one of our administrators say, if you are not at the table, you end up being in the menu. So I think that's very important. So you need to really, see, politics is not a bad word if the person who uses it is not a bad person. Because politics influences policy. If you want to influence or bring hand surgery on a scale, then you have to influence policy. And there will always be some good side even to bad politicians. I think what you need to do, you need to influence that part of it, you need to. If your ideas are good and there is no hidden agenda, usually things go through. And every specialty needs champions. I think if you can't be one, help your colleague who is one. I think that's very important. Ultimately, you need perseverance and you need to work till it works to that impact. So recently we had a major Diabetic Foot Society of India meeting, and the IAS officer who spoke and with whom he had done a great job in trying to get this thing in Tamil Nadu, he said they put this for 2 slides which I am taking from them. One is epidemics or social in origin, and the way to combat epidemics is political and not medical. I think Virchow said this. I think it's so true for COVID. I think it's so to COVID. The second sentence which I like to take was National Health Mission said, scientific inputs with statistical evidence finds policy approval. So that again is a very heavily loaded statement. It comes out very nicely. Scientific inputs, statistical evidence finds policy. I think if we are able to provide it, and then I'm sure now we could influence and make a great impact in the society. Thank you so much.
Is there any question or comment about Dr. Sabapathy's presentation? Well, thank you very much. That was a beautiful presentation. I do have a tiny little comment, though. You say do not complain. Well, yes, let's not complain, but when there are problems, not only should we address them, but we should also discuss it with the one above, and that's not complaining, but that's, trying to solve them, maybe. Okay, I'm going to try, and please excuse me in anticipation. I would like Dr. Balakrishnan, yeah, to come up stage and tell us about the role models in action, inspiring excellence in hand surgery.
Good morning, everyone, and my dear chairpersons. I have been asked to talk in this physiological talk, psychological talk, whatever you call it, role models in action. Then it was converted into inspiring excellence in hand surgery. This inspiring in hand or any other surgery, I have selected a few points. First is to commit for lifelong learning. You should be able to continuously update your knowledge and skills, because knowledge is the power. Attend workshops, conferences, and pursue further education. Encourage a culture of lifelong learning among your students. And develop a strong communication skill. This is very important to converse or to communicate to your patients, your colleagues. Practice active listening and empathy. The listening is the most important thing, whether it be a patient or your colleague. Provide constructive feedback and mentorship to students. Then, having learned the skill, you must positively and effectively use it for your patients. Explain the medical procedure and the conditions clearly to patients and students. And today's scenario, it's very important to explain to the patients. Foster an environment where students feel very comfortable to talk to you, to question you. Provide support and reassurance to patients in distress. And exhibit your clinical competence wherever it happens. Demonstrate proficiency in medical procedures and decision making. The decision making is very important. Yes, this was also, very much told by Padma Shri Manjunath. Use evidence-based practices and protocols. Show confidence and decisiveness in critical situations. That's the most important. Build a professional network. Just because you are a boss or you are a consultant, always connect with your mentors, your seniors, peers, and other professionals to build a nice professional network. Join medical associations and attend networking events. These days are so common. This will give you a lot of energy, advice, and whatnot. Ensure patient care. This is the most important thing when you want to become especially a specialist or respectable fellow in your specialty. Prioritize patient needs and advocate for their rights. Be proactive in addressing patient concerns and improving quality care. Engage in community health initiatives and public health advocacy. Demonstrate ethical practice. This is very, very important. You should be honest. Whether it's right or wrong, you should be honest. And your integrity should be always maintained. Ensure patient confidentiality and informed consent. Avoid conflicts of interest and maintain professional boundaries. Promote teamwork and collaboration. Initially, you had a teamwork with your peers and seniors. Now you must collaborate with your patient and also to the other consultants or other specialties. Value and incorporate input from all team members. Model effective conflict resolution and cooperative problem solving. Stay organized and manage time effectively. This is very important. Your work life and your personal life or a family life should be separated and should never become burnout. Prioritize tasks and manage your schedule efficiently. Use technology to keep track of appointments and deadlines. Seek feedback and reflect on your practice. This is important not only for you to advise to your junior colleagues. Enhance your leadership skill. This is very important. Over the years, as you are doing, you don't think that you have achieved your goal. Take on leadership roles and responsibilities. Not only head of the department, you must be able to communicate with the administration and the hospital to take up leading roles. Develop skills in team management and decision making. Cultivate cultural competence. You will always see diverse culture in our patients and in our colleagues. Provide culturally sensitive care to our patients and also our fellow human beings. And it's above the also stressed engage in research and innovation. This is very important. When you do your sort of a work over a period of time, you should naturally get into research of what you have seen, multiple cases, whatever you have done. And encourage your students to get involved in research projects. Stay open to new ideas and innovate practice in medicine. Stay adaptable. This is very, very important. And open to change. Like nowadays, 3D imaging, artificial intelligence are all coming in the way. You must be able to adapt to these things and come forward. Artificial intelligence as role models. Artificial intelligence is transformative tool in hand surgery. It complements rather than replaces the essential role of human surgeons and role models. AI will never fully replace role models in hand surgery as human skills, intuition, and mentorship remain irreplaceable. The future of artificial intelligence and role models in hand surgery. The future lies in collaboration of artificial intelligence empowering surgeons and role models guiding how AI is best applied. Surgeons of tomorrow will be those who master AI tools and also combine human expertise and their timeless values. So just I put it, role models for artificial intelligence is the future of the hand surgery. This is how you have to improve in your own specialty, and it's also useful for the rest of the specialty. Thank you.
Thank you, Professor Bala sir, for this guidance. You've been a great role model. 30 years ago, when I was doing my fellowship at Stanley Medical College, we have observed your administrative skills and ability, and then you brought us all of us for where we are today. There are so many students in this hall who admire you, and many across the world too. Thank you for being a role model. We'll try and emulate your advice. Thank you so much.
Thank you.
Can I call upon Dr. Amitabh Gupta to speak on surgical success stories? What techniques have benefited my patients?
Thank you so much. Thank you for the invitation to speak on this. This is a philosophical talk, and I will take it as a personal journey. The success stories, the techniques that have benefited my patients in microsurgery, plastic surgery, as I'm traditionally orthopedic surgeon, arthroscopy, joint reconstructions, nerve transfer, tendon transfers, internal fixation, arthroplasty, children's hand surgery, and intense study of anatomy, and some development of wisdom when to do and when not to do surgery, and innovation, imagination, and curiosity. It's very important to recognize the gurus. In India, we say, Akhanda Mandalakaram Vyaptam Yena Characharam Tatpadam Dashyatam Yena Tasmai Shri Guruve Namaha. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Shakshat Par Brahma Tasmai Shri Guruve Namaha. So in microsurgery, I learned from Professor Ackland, Louis Schecker, Sumin Sai, and then my fellows. Some of the best microsurgeons in the world, Beng Hai Lim, Hung Chi Chen, Jin Soo Kim, Dong Chul Lee, and Song Young Woo. Plastic surgery, Professor Adesoy taught me the Adesoy flap. Robert Ackland, Louis Schecker taught me all the free flaps. David Elliott taught me all the local flaps. I worked with Simon Kay, Guy Fouché, Steve McCabe, Steve Morris, Beng Hai Lim, and Michael Sincere. Arthroscopy, Dan Nagel taught me how to do arthroscopy, and Hill Hastings. Nerve and tendon transfers were G.C. Das and Harold Kleinert. Internal fixation, Hill Hastings, Jesse Jupiter, and Uli Buchler. Arthroplasty, Peter Lunn and Hill Hastings. Children's hand surgery by Louis Schecker and Harold Kleinert and G.C. Das. Anatomy, Professor Ackland and Harold Kleinert. Wisdom, my main mentors, Dr. G.C. Das. When I was training in India, there were 5 hand surgeons, and I was fortunate enough to get training by Dr. G.C. Das, Dr. Harold Kleinert, and Frank Burke in Derby, and innovation, imagination, curiosity from my father, Kamakya Gupta. So these are my teachers, my primary teachers, and my colleagues who gave me wisdom and knowledge, and my fellows, Dr. Wu here, and one of the greatest microsurgeons from Korea, Dr. Dong Chul Lee and Jin Soo Kim. These are my fellows who have continued to teach me over the years. When I was in Louisville, at one point when I was fellowship in charge, I had 35 fellows from all around the world. And they taught me a lot, tremendous amount of knowledge and expertise from around the world. They taught me, my teachers taught me and helped me refine my techniques of microsurgery so I could give results like this to my patients. Even undergoing these complex transfers, twisted two-toe transfers, super microsurgery, replanting the tips of the fingers, tips of the thumb like this to give results like this, or to do free flaps to cover defects like so. So these are the techniques which I've learned from my gurus and which have helped my patients. Planning, how to take care of problems like this. Take a free fibular flap, divide it into 2, and do a flow-through free flap so that you can get a coverage of the skin as well as the bone reconstruction of the same setting. Or when you have a complex injury like this, how to take care of that. And we debride, we reconstruct the bone, and then we cover this, do the reconstruction of the vascular system of the thumb, and then cover that with a free flap so that we can start early active movement of the thumb, resulting in this amount of functional return. We heard about free gracilis transfer. I love this operation. Doing free gracilis transfer for lost finger flexor function has been very, very helpful for my patients. And this is one example of this case. So we'll skip that. Dr. Adesoy taught me how to do these small little flaps, and these have helped my patients tremendously. The local flaps I learned with David Elliott. We learned the Quaver flap, which is extremely useful, and must recommend it to the residents and fellows. It's very useful. The posterior interosseous artery flap, which is a flap which I love a lot, which is for covering. Internal fixation for complex injuries as well as simple injuries is a fundamental thing, following the AO principles, to be able to fix and then get the patient moving, and then also to do coverage. I also do whole upper extremity, so do total elbows in say, complex fractures in the elderly patients or in arthritis. Louis Schecker taught me to do the distal radial joint arthroplasty. And his technique of replacing the DRUJ has tremendously helped the patient. I had a great interest in children's hand surgery, and one of my favorite operations was doing policization. A well-done policization is an extremely beneficial for the patient for function as well as cosmesis. Professor Ackland taught me the importance of anatomy. I worked in his lab for many years, and then subsequently developed my own lab, and we dissected 400 cadavers over the years, and we photographed it, and subsequently this was published as a grasping hand. Dr. Kutz and Kleinert, who pioneered flexor tendon surgery, have taught me how to do flexor tendon surgery. One of my important interests was biomechanics, and I tried to answer the question, does the motion path of a digit in grasp and release follow specific mathematical patterns? And we're able to do this in the lab and show that and published it. My dad taught me innovation, and I did some innovative work in developing this brachioradialis wrap, which is a way of stabilizing the distal radial joint, taking a brachioradialis, leaving it attached to the distal part, and using as a watch strap to stabilize the DRUJ. And we'll publish the results very soon. This is in a case which has a malignant giant cell, not malignant, a recurrent giant cell tumor, which had an implant, and here is a 15-year result of this operation. We developed this total wrist arthroplasty system. I designed this when I was a fellow, and subsequently received a patent for this. This has been done since 2003 now in the United States and around the world, and it has helped my patients regain function in the wrist when everything else is lost. So I must, again, pay homage to my gurus and my teachers, my colleagues, my fellows who have taught me over the years techniques which have helped me take care of the patients tremendously. Thank you very much.
Thank you very much, Dr. Gupta. This is an extremely impressive summary of a life full of work and adventures and innovations, and I wish I had been one of your patients. Thank you so much. So now we're calling to the floor Dr. Bhaskarananda Kumar, and he's going to tell us about propagating hand surgery, my mission to advance the field in India.
This is not a philosophical talk. This is a practical talk that I'm going to give you. I was the president in 2005 of the Indian Society for Surgery of the Hand, and the conference was held in Cochin. I was a lucky man because when I was the president, I had a great secretary, Dr. Raj Sabapati, who did all the work and I took the credit. The conference was conducted, the organizing secretary was Dr. Jay Kumar. In the presidential address, I said, our association has got big guns like Dr. B.B. Joshi, Dr. Venkateswamy, Dr. Srinivasan, Dr. Palande, then Dr. Fishy and all that. With all that, our membership was only 230 in 2005. Then I proposed a question. This was in my mind, why the number is so low? Can't we increase it? And how to improve this number? I mooted the idea of basic hand surgery course in my presidential address. That was one presidential address where I printed my address and distributed it to everybody. Aim was to encourage the youngsters to take up hand surgery, because all big guns, after some time, they will not be there. Youngsters must take it up. And who are the youngsters? Those who have just done their MS general surgery, MS orthopedics, or MSH plastic surgery, and also the final year students of this specialty. Dr. Mukund Tatte, in the general body meeting, said that I should be made the chairman for 5 years to conduct these basic courses throughout the country. For 5 years I conducted about 32 centers in our country, and also outside the country, in Nepal, one in Sri Lanka and one in Bangladesh. I'm happy to say that ISS membership increased in 5 years, and today I'm very happy to say that it's nearing 1,000. What is this basic hand surgery course? Presentation with the relevant slides, more of interactive session. If delegates do not ask questions, sometimes I point out and say, you tell me whether this is right or wrong. And guidelines to the speakers are given through phone calls in the beginning. Previous week to the meeting, these days we are conducting webinar meeting with the speakers so that everybody speaks on the same thing and there is no repetition of their talking when others are speaking. We divide the whole system for 1.5 to 2 days program, and we said capsules, for example. First one is an introduction, most of the time I deliver it. First aid, which is not taught in any textbooks today, was the most important thing because patients come with dangling hands without having any first aid at all. So I thought that is really required, and we have to teach the society, not just the doctors. Then the clinical evaluation, the first capsule, and second capsule, anesthesia in hand surgery. In fact, Ganga Hospital in Coimbatore taught us this. That is very important to give to know something about anesthesia, because we hand surgeons need to tackle them very early. Radiology of hand injuries, once again, is a topic which is often neglected. Then we have debridement. Then in the course, routine tendon injuries, nerve injuries, fractures of the hand, and many such things are included. And we also included hand mobilization, hand therapy, which is very important, because I always tell the patients that my job is 50%. Second job, 50% is yours with the help of therapists. In the guidelines to speakers, earlier we were calling anesthesiologists to talk on hand surgery for the basic course. And nerve conduction study also we used to request a neurologist to come and tell. But most of the time they were not doing the job that we wanted them to do. These days, some of the people are talking on anesthesia and hand surgery, and nerve conduction once again. Now, how to interpret a nerve conduction instead of telling how to do a nerve conduction, interpretation, etc. And Anil has been doing a very good job of that. We always say, let's talk in these things and more of interactive section to drag the people to understand that we want them completely included. How many hand surgeons do we need for our country? I was just going through the statistics. We have about 800 districts in our country, including in the states as well as union territories. There are 8 mega cities. Big cities are 40, and small cities and towns are 4,000. I arbitrarily thought that we should have at least 5 hand surgeons for each district. Mega cities probably require, one city requires 50. Big cities require probably 25. Small cities and towns, I feel that they require about at least 5 hand surgeons. If that is the thing, we require 40,000 for all the district. Mega cities require 400. Big cities require about 1,000 hand surgeons. And small cities and towns, 20,000. A total of 20,000, 25,400. We are not anywhere near it. We require very much more number of hand surgeons in our country, because my job, main even today, is undoing the things what others have done. They have spoiled the hand, they come to me with all kinds of grotesque deformities. We are trying to undo that. Can the primary care be better, for which we are conducting this basic hand surgery? In my endeavor, I should say that Anil Bhatt and Ashwatacharya has stood by me throughout my career. Anil Bhatt more so recently, he has been appointed as director, course director. He takes most of the headache, and I'm only dragged to the conferences so that I deliver the introduction speech and some other topics. Ashwatacharya is behind the screen preparing the health stocks for me. If you wear jewels, somebody can steal it. If you have knowledge, nobody can steal it. Knowledge is like gold. If you can transfer that knowledge to others, it becomes a gold with diamonds. That is called the jewel that cannot be stolen. Thank you very much.
Thank you, Dr. Bhaskaran Kumar, for this excellent, inspiring, words. After conducting more than 75 basic hand surgery courses all over India, I have been part of some of these courses, and then it's really made a lot of difference, because you have already also stressed on what not to do rather than what to do, on not only what to do. So what not to do is so important, because we see complications day in and day out, how to pass in the wires. You have structured the program with you and Anil, but structured program as to the videos, the techniques of simple procedures. So that's made a lot of difference to all of them. So what's your, in one single sentence, if you would like to advise the younger generation, what would it be? In one single sentence, if you would like to advise the younger generation, what would you advise?
Please come to hand surgery. See that it is developed. Thank you very much.
Thank you, Professor Bhaskaran Kumar. Can I request Dr. Anthony Burgess to speak on the most boring aspect of surgical practice is usually the most important.
Thank you very much. We're moving slightly off topic now, and I'd like to thank Dr. Sudhir Warrior for breaking the ice on this topic. So I'm going to talk about risk management. It's my personal approach, something I've learnt and developed over the years. My disclosures is that I have injured patients, and I have been sued, and I have terrible handwriting. So what is the difference between surgery and an injury? We're always cutting people. Surgery is the only legal way we can actually injure a patient and have them thank us for it and even pay for it. And a patient accepts this injury if the outcome results in the resolution of their symptoms and improved function. But if surgery leaves a patient worse off and with other damage, deterioration or new symptoms, loss of function, then the person feels injured and may seek compensation or other forms of redress. So most patients understand that complications can occur, but how can we manage these complications? How do we prevent injury to our patients? How do we manage those patients we have injured? How do we minimize the medical legal impact? And how do we look after ourselves? So a database from United States shows that carpal tunnel and fracture fixation accounts to about 70% of compensation claims for hand and upper limb. Carpal tunnel, particularly nerve injuries, weakness, CRPS, and fracture fixation, mostly malunions, weakness, and some nerve injuries. So as far as litigation risks are concerned, that surgery on the left is a very high risk operation, and the surgery for that one on the right is a very low risk. We've all seen this before. We all know about the Swiss cheese prevention. The aim is for smaller holes and many more layers. And it's those layers that seem to be the boring things. Communication, surgical consent, preoperative checks, timeout, it's all boring. Communication, the initial consultation, discuss the diagnosis, discuss alternative treatments, explain your decisions, provide the patient information. And I'm often drawing diagrams on bits of paper to explain to patients what they can do. And I think perhaps if you can't draw, you shouldn't operate. Allow patients to question anything and obtain a written consent. And on that consent, you should include the site, the side, the surface, the digit, and use words, not symbols. They can be confused. Clear handwriting is one of my problems, and so you have to watch out for that. So what do you go through the patients with their consent? What do you consent them with, and how much do you tell them? So for many years, the Boland principle was the basic consent process. That is, you consent a patient, you give them risks that are accepted by your peers. In '92, that was thrown out, and we now have the Rogers and Whittaker system, where basically you have to advise a patient of any risks to which they may attach significance. So there could be anything that the patient decides is significant, which suddenly changes what you actually have to consent a patient for. So once you've consented the patient and gone through all of the possible outcomes, your final preoperative check when the patient is in the anaesthetic bay, read your notes again before seeing the patients. See the patient in the anaesthetic bay. Ask the patient to tell you what you're doing. Examine the site of surgery and mark the site of surgery. And then team timeout is now almost essential in our hospitals at the moment. I'm not sure here. But it's where everyone in the theatre stops. We confirm the patient details, make sure they did bring the right patient into theatre, which does sometimes go wrong. Confirm the surgery and the site is marked, and then confirm allergies and significant medical conditions. It's all more boring stuff. But what happens when something goes wrong? So there are 5 most important lessons for the management of adverse incidents and complications, and that's communication. Tell the patient what happened as soon as possible, why it happened, what are going to be the consequences for that patient, what can be done to minimise the problems, and be accessible to the patient and their relatives. Notify the hospital and your indemnity provider, document everything. Minimise any extra costs for the patient as far as possible, and don't lie to the patient. They will know, or they will eventually find out. Poor communication can only make things worse. Good communication can only make things better. So be open with the patient. It's really hard, and it's something that you have to do. And like Dr. Warrior, you actually want to turn all the lights off so no one can see you. But when you are confronted with these adverse outcomes and a litigation process, it's really distressing, and it's a very confronting and challenging time. You're embarrassed, you're really stuffed up, your reputation you feel may be destroyed, you lose confidence, you question your own skills, and there are obvious financial implications. So the first thing is to obviously accept that it happened. Self-reflection, why did it happen? What can you do to make things better? You can't undo what has been done, but you need to try and get the best out of it. And seek support from trusted colleagues and family. Talk to your friends, your colleagues. You may not know, but they've probably gone through exactly the same thing. So it's going to happen to all of us. No one is perfect every time. We are human, so we must learn from this. So, confession time. I had a patient with a volar wrist ganglion that I approached from the dorsal aspect. It doesn't work, it's very hard to do. But my consent form, when I looked at it, said removal of wrist ganglion. I didn't see the patient before he was sedated. I didn't mark the patient. Timeout wasn't a routine at this time. So this is in my first 5 years of practice. So I got sued. The findings against me, but there were no personal penalties. Minimal compensation to the patient, as the court fortunately determined that there was actually no loss, and the insurance payment covered the correct surgery. Confession 2. An endoscopic carpal tunnel release performed by a trainee under my direct supervision. They divided the median nerve, which was recognised at the time and repaired. We discussed with the patient immediately post-operatively and with the family. We provided all care that they needed for no charge, open and frank discussions all the time. The outcome was that the patient's first comment after the discussion of the incident was, "Well, you did tell me that this was a possibility," and no further action was taken. So carpal tunnel, a very common problem. None of us ever divide median nerves, but you still need to tell them that is a possibility, and that will save you an awful lot of heartache. So surgical care is always improving, but patients' expectations are increasing. They're better informed, claims for negligence are increasing, and lawyers are still hungry. So prevention is boring, but going to court is never boring. Thank you.
Thank you so much for this very boring but valuable presentation. As you said, I think we've all been faced with this kind of problems, or if we have not yet, it means that we are too young probably, but it's bound to happen. And we can only agree with you on all your recommendations. And I would personally agree that communication is the best thing that we need to learn when dealing with problems. Are there any comments? Yes, Dr. Sabapati.
Tony, this is a fantastic presentation, Tony, because I think Tony and myself are co-fellows in Loyola. I've known him for long. And when Dr. Bhaskar Kumar was president and I was secretary in the Cochin conference, they asked me to give a talk on complications I wish I never had. Okay, that was the topic that was given. So I searched for all the worst complications we had. There are quite many. And then we found that all those complications were not due to innate lack of any surgical skill or anything like that. All of them have been just because we have missed a very small thing, non-surgical aspect of it. I think that was all the complications were, and that talk was highly applauded. But I really found every time I had that complication, when we went into the root of the problem, we are not seen, we are not talked, and not the post-op rounds have been a little bit off. It has been like that. So, Tony, this has been a fantastic lecture. I think we have to go over it again and again. And whatever phase of our life, I think we have to read it again. Thank you.
Thank you.
Any other comment or question to Dr. Berger?
Well, in a litigant society, what we are facing today, all across the world. So, are we compromising on the outcome in trying to be safe?
I think being safe has got not much to do with medical care or surgical care. We care for our patients. We do the surgery that we feel is the best for them, having discussed with the patients. The problems are communication. Patients, most of the time, will know that complications can occur. We might go in with something, four-corner fusion, think this is going to be the best option for you, and we decide that rather than PRC. We go ahead, we do that, and we get a non-union, a wound infection, or something like that. The surgical care was good, but we had a complication. So I don't think we need to be scared of operating, but we need to keep the patient informed, and they are part of the decision process. And if they know what's happening, we don't have many risks.
Thank you, Dr. Berger.
Excuse, sir, can I ask one question?
Yes?
Yes, sir. Sir, do you have printed a common consent form, or do you write all the complications separately while discussing a patient?
It's part of my notes. I write down everything that I discussed with the patient.
Okay, so you mention whatever you discuss with the patient.
I'll make a summary note.
Yes.
Like when I'm talking about endoscopic carpal tunnel, I'll
Yes.
put down a note that risk of infection, nerve injury, and conversion to an open carpal tunnel.
Okay, thank you.
I have had some difficulties, not so much with the patients, but with the insurance, with my insurance company. Have you had trouble with the people who are supposed to defend you in front of the patients?
The most important thing, what they don't know what we talked about, so unless we've written it down, they don't know. So I think the only problems with insurance companies if we don't document what we've talked about, particularly with consent. So if we've got a documented consent form and we've documented it in our notes and we send off a copy of the notes, the insurance companies are quite happy with that. But if we have no documentation that we've obtained consent and what we've discussed, then we have a bit of a problem because then it becomes he says and she says. So I think the only problems are documentation.
I was more thinking about the direct relationship with them and with their lawyers. When you have a problem, then the lawyers comes in and say, okay, this is what you should say, this is where you should keep silent, this is what you should not say, and I find it sometimes a little difficult to comply with.
Yeah, I think, the lawyers, there are lawyers for the plaintiff and there's lawyers for the insurance companies, and they will try to sort of coach you in what to say in the court. And I think you just got to speak the truth. You're not there to defend the insurance company, not there to save their money. I think, truth. Once you start lying, particularly in court, you'll come unstuck. So I think if the lawyers for the insurance company want you to slightly modify what you've said to save them money, I think you're in big trouble. So it's painful, but I think you have to come clean with it and say that, give them the truth, what happened.
Thank you very much. So I think we have a little time.
Yes, so some more time for discussion before we go on. The common questions we face these days, will I be 100% okay? The common questions asked by the patient. Anybody would like to guide on how will you address this patient? Dr. Nethe, how will you talk to your patient who will ask you what percentage of improvement will I get?
It's
because his decision will make a total, your answer will make a decision, change the decision.
When we are consulting the patient, many times patient will ask this question, Doc, will I be 100% fine? I think you have to diplomatically answer this very well, because one thought is always there in the mind, if I explain everything, all complications, the patient may not turn up for surgery. So you have to explain the complications, but tell them that you will take extreme precaution not to have any complication, and you have to ensure that even if there is some complication, you will be able to tackle it. They are more worried about it, that if in case during surgery there is a complication and you are not able to tackle it, it will be a grievous problem. So you need to ensure, but you cannot say any time that it will be 100% safe. I always tell them example, if I am going by a road on Indian roads by a vehicle, I am never sure after 4 hours of journey I will reach at the destination. That's same for the surgery, including your life during the surgery.
Yes, doctor.
Dr. Diwakar, I think that it is a very pertinent thing, because every patient, when he comes before you, the only thing he is worried about is what you are going to do, and certainly he will ask you, will I be 100% better? And I think that I will never tell them that you are going to be 100% better. I am doing for the best. This is the maximum we can get. And as far, from the lectures you have heard, every consultant must be aware of all the complications, because if he or she asks, you have to be honest and tell them. And one should not be worried if they want to take second opinion. It is always a good idea, because if you tell them the complication and they go somewhere else and they find that what you have said is correct, they will come back to you. So honesty and integrity will help. And you have to be very, very much up to date, because when you go to the court, it is you who have to decide, because not the lawyers. They don't know much. I have fought the case and I have won, because lawyers didn't know. They always want to complicate. But if you are right with your references, you will certainly win. Thank you.
Thank you, Dr. Devaka. That was a good, thank you for the advice and the take-home message. We had a great session with good, yes, Dr. Mudgal? Yeah,
Bharat, it's a very pertinent question you ask about perfection and normalcy. And one of the commonest causes for lawsuits, not malpractice, lawsuits. There's a big difference between the two. One of the commonest causes for lawsuits is malunion in a distal radius fracture. And oftentimes we get asked, am I going to be perfect? Am I going to be normal? Over the years, my response has been, you're not going to be perfect, you're not going to be normal, but you will be functional and your brain will learn to deal with a new normal. And that new normal is going to take you 12 months. And I find that instead of giving a negative response, if you give a hopeful response with a fairly protracted time span, I think it helps the human psyche. Hope springs eternal. But if you give them, oh, you'll keep improving for 5 years, that's unrealistic. So this is, I just give them a time span of 12 to 18 months for improvement, and it gives them something to look forward to. So that's the strategy that I've utilized.
Thank you, Dr. Ravi Gupta. Yeah. Yes, Dr. Ravi Gupta, please.
Actually, this is the reiteration of the same, what everyone is saying. The way I explain to them, even in the cases where I have 100% restoration of the anatomy, the patient asks, will I be 100% all right? I say, I don't know. Because biology is not predictable. Physics and mathematics can be predictable. I give them the example of sowing 2 seeds from the same fruit. The outcome may be different. So that's the way. I never ever say 100%, even if you have restored 100% anatomy. I tell them this is an injured wrist which has been repaired. The opposite wrist is uninjured wrist. They have to be different. Yeah.
Thank you, Dr. Gupta. Dr. Caroline is...
Yes, I would like to make a comment, especially regarding the first 2 presentations about increasing hand surgery and in India, and about role models. This is the first time I'm here with the society, and I'm extremely thankful and extremely happy to be here, and very amazed at this growing society and how fast it's been growing, and of all the things you have achieved. And we heard yesterday about all the courses and all the new things that have been done thanks to your society. Being a woman, I still have one little comment. I look at your very nice group here, and I see more ties than I see dresses. And I think probably this is a time here, and I don't want to tell you what you have to do, but this is just a comment from my part. Maybe the time has come here for this society to give a helping hand to those female members of your society. You have wonderful young women here. I'm sure there's wonderful young men. but please help them climb the ladder and become role models themselves.
Thank you for that piece of advice, and we'll certainly emulate that. Thank you all for the very interesting session and involving the discussions. We close this session. I thank my co-chair, Dr. Caroline. Close this session, and we go on to the next oration. Thank you.
Yeah, we'll start the oration at 11:45. We are waiting for the other halls to finish. Meanwhile, we can take some questions, or we can take a 5-minute break. Few announcements. The dinner will be not through the barcode. You have to collect the coupon, the dinner coupon and the banquet coupon from the registration counter. Please note, the dinner coupon and the banquet coupon has to be collected from the registration counter. And if you're not registered for the banquet, you can do that at the registration counter.